So chest pain in the emerge, it's the second most common complaint for patients presenting to Canadian emergency departments. 14% of total visits. That kind of parallels here at LHSC. I think it's about 17% of all comers here have a trope ordered, whether that's by nursing or by us, and about 500,000 visits annually. That picture up there is meant to be a little more than a joke because sometimes we're surprised by the troponin that we find, and other times, we're sitting there listening to the patient's story, and given that they've only had 2 hours of chest pain, technically we're obligated to repeat troponin in 3 hours, despite the fact we feel that the patient is very low risk for ACS or ACS-related events. So here's the current algorithm that was brought in 2012. And when I kind of first learned this algorithm, I assumed that, so we adopted the high sensitivity troponin T, which is made by Roche. There's only one maker of the troponin T for high sensitivity, but there's multiple for the troponin I. So I assumed that Roche came out with this high sensitivity troponin and kind of told us how to use it or instituted this algorithm. But what actually happened was it was three people. It was Carl, Pallav Garg, and Vipin Bayano, the biochemist here, that sat down together, went over some of the available evidence at that time for high sensitivity troponin, which was still fairly new, and came up with how best to use that here at LHSC. The way we use these Roche high sensitivity troponins here are not the way they're used elsewhere. Every institution has its own specific protocol, so for what's defined as ACS for us or concerning for us may be different for other institutions. For example, ours is a delta of 10 at 3 hours. There are other protocols with deltas of 10 at 6 hours, a delta of 20% at 6 hours. So very different, and that's important to keep in mind when we're assessing these studies. So there are some problems with the current algorithm, and some of those problems were addressed initially in 2012, as per the concerns from the group. So the concern was, is it too sensitive that it compromises specificity? So are we overly cautious, or are we not cautious enough? Because the troponin now that we use is better at picking up elevation in troponin, or the high sensitivity troponins that we're using now, we can detect troponin earlier, and we can detect more subtle elevations. What does that really mean? And what are others doing elsewhere? So high sensitivity troponins are not available widespread in the US. They are using them at some research centers in the US, some university institutions, but by and large they are not using high sensitivity troponins in the States. They're not FDA approved, from my understanding. So Ottawa still is using conventional sensitivity troponins and is thinking about soon switching to a high sensitivity troponin I believe. And the question we have is, are we doing unnecessary repeats? So as a resident, we kind of have the luxury of working with many different staff, seeing how many different staff operate and kind of the gestalt that they use. And even in speaking with staff outside of the clinical setting, we know as residents that we're not always necessarily following this algorithm to a T. The patient who has a troponin of 60, who has chronic renal failure or CHF, we may discharge home because that's their baseline troponin, but if we were to strictly follow the algorithm, that's a cardiology consult for an elevated troponin above 50. So these are important things to keep in mind, that we aren't necessarily following the algorithm as strictly as we sometimes think we are. So with the switch to high sensitivity troponins, this was what AJ looked at a couple of years ago when the high sensitivity troponins were introduced. And you can see here that initially the positive results for the conventional sensitivity was about 9.2%, which increased to 10.8%. So we were having more positives when we switched to the high sensitivity troponins, which led to more repeats. We had about 12.7% increase in the number of repeat troponins that we were doing. So the cons were that we were doing more repeat testing. But the pros were that for those that needed repeat testing, there was a shorter amount of time in the department and a shorter turnaround time and diagnosis for ACS for those that needed cardiology consultation. So we can see here that the percentage of patients that were consulted after repeat troponin testing went from about 20% before 2012 to about 36.5% after 2012 when the high sensitivity troponins were introduced. This number may have changed over the past year or two, just to let you guys know, as we become more comfortable with the high sensitivity troponins, but the number still holds true. And we can see here that the troponin has value in terms of, even if it's less than our 99% cutoff of 14, if the troponin is initially undetectable, there's a very low risk of adverse events in those group of patients, despite being early presenters or not. So, is there a better way? And I know that there's currently a lot of different evidence out there supporting accelerated diagnostic protocols. When the high sensitivity troponins came out, we said, this is a better way, or it was thought at that time, and still is, as we're leading now toward high sensitivity troponins becoming the standard of care. So in terms of a better way or alternate protocol than what we're doing now, there was a study called the ADAPT trial, which looked at nearly 2,000 patients and had a primary endpoint of MACE. A lot of these studies, just for power reasons, look at major adverse cardiac events, which is a composite outcome, generally combining things like PCI, CABG, need for revascularization, MI, and oftentimes whether it's 4 weeks or 6 weeks. So about 20% of patients were classified as low risk, and again, this was using the conventional, not high sensitivity troponins. So how were you considered low risk in this ADAPT trial? So in order to be considered low risk, you had to have a conventional troponin at 0, so at time of presentation, and 2 hours after, that was less than the cutoff. So for us, that would have been 14, just for a reference. And you had have no new ischemic changes on ECG. And the caveat here is that you had to have a TIMI score of 0. Now, you guys are taking a look at the TIMI score there. You guys can probably appreciate that over at UH, there's very few patients that would meet this. So this means that any patient 65 or over who's taken aspirin in the last 7 days automatically has a score of 2 and would no longer be considered low risk. However, they did only have one patient who had an adverse outcome showing a sensitivity of 99.7%. They used a secondary analysis looking at a TIMI score less than or equal to 1. So that would be like a 65-year-old or a 70-year-old who happened to not be on aspirin. And they saw that they had 9 missed cases of major cardiac events. So the sensitivity dropped. This study was repeated using 2 cohorts. The initial cohort was actually the cohort from the ADAPT trial that I just mentioned, and another was from the Apache study. So what they did was, when those trials were done, they also drew at that time blood work that was always intended to have these high sensitivity troponins drawn and to be later analyzed in this study, which I'm going to talk about now. So this accelerated pathway used a non-ischemic ECG as previous, a TIMI score less than or equal to 1, and a normal high sensitivity troponin at 0, troponin I at 0 and 2 hours. Again, the primary endpoint of MACE at 30 days. So for this study, the primary cohort, as I mentioned, was the ADAPT, and the secondary was the Apache. So decent numbers, 1,600 patients and about 900 patients, and we saw that we could classify about 40% of patients within 2 hours as considered low risk. And you can see here that overall, within the 2 cohorts, only about 3 patients had a major adverse cardiac output, or a major adverse cardiac event. So the sensitivity, although there's no officially defined cutoff in terms of what is acceptable, what is an acceptable miss rate for ACS or MACE, the general consensus appears to be about less than 1%. So that would meet that definition there. And it's important to look at, what are these misses? Because we talked about, we diagnose ACS based on our protocol. For example, a STEMI is a STEMI, but an NSTEMI, for example, would be the classic story, or maybe there's some ECG changes, the troponin elevation, but it really varies between hospital to hospital in terms of what is considered positive for troponin elevation. So the 3 misses here I just want to highlight for this study. The patient 1 had an angiogram 5 days after presentation showing completely normal coronaries, but it was diagnosed as an NSTEMI because there was no other cause of troponin elevation. And if you remember, the inclusion criteria to be low risk was that you had to have a negative high sensitivity troponin I at 0 and at 2 hours. that was true for the high sensitivity troponin, but the patients were treated based on the conventional troponin that the centers were used to. So that means the conventional troponin was elevated, whether it was a false negative, which can happen, or whether it was that 6 hours from the time of repeat was enough to have the conventional troponin elevation. But you wonder with completely normal coronaries, and you see the next patient with a maximal stenosis in the LAD of 30%, for them to truly have an end-STEMI, I mean, I'm not sure that that would classify, at least in our center. A lot of these studies are done in either the States or in the Netherlands. And patient 3 had an exercise stress test the following day, which was completely negative. So the question is, can we do better? So there was a prospective 1 hour algorithm that was used to try to further accelerate things and say we can do better than this 2-hour protocol. So it had a little over 1,000 patients, and it had so in order to be low risk, you had to have a conventional troponin less than 12 in terms of troponin T. High sensitivity troponin less than 12, and that delta had to be less than 3 within that 1 hour. Now, in speaking with Vipin, there are some concerns about this because in order to be high sensitivity, you have to have at your 99% cutoff a plus or minus of about 10%. So that means our 99% is 14. So at 14, 99% of a healthy population should not have a troponin above 14. So for 14 for us, a high sensitivity troponin has to have plus or minus 1.4. Now, as you increase in your troponin value, the test becomes better. But as you decrease, so around 3, 5, it's less precise. So if we have a trope of 7 or 8, do we know for sure that up to 2 nanograms per liter are not just lab variation? So there is some concern with this protocol. Nonetheless, this study reports a sensitivity of 99.6%. For the rule-out criteria. The other important caveat to this study is not only rule out early within the first hour, but it lets you know who you are concerned about and maybe getting cardiology involved sooner, because as we all know, calling cardiology, even if there's a patient that you're concerned about, you're calling the CCU resident, R2, comes down after rounds, when they're able, who reports to the fellow, who reports to the CCU staff, who reports to the interventionalist, and finally we get things going. So, I mean, especially for us in our resource-strained system, I think earlier diagnosis is very important. So going one step further and say, what about if we took only undetectable troponins when patients came in? So for us, that's less than 3. For some centers, despite the fact that for troponin T, high sensitivity, Roche is the maker of all of them. I'm not sure if it's the analyzer or what that causes some labs to cut off at 5. But there was a study with almost 15,000 patients showing a less than 0.5% missed MI rate at 30 days with an initial trope less than 5. There was another study that was done having a little bit less than 1,000 patients showing a sensitivity of nearly 100% with a high sensitivity troponin T less than 3. So that means no matter when they came in, so whether it's an hour and a half or 2 hours after the onset of their chest pain, if they have an initial high sensitivity troponin less than 3 that's undetectable, there's an extremely low risk of major adverse cardiac events. And the second study that I'm showing here, this held true for early presenters. However, there was another study that was done. It was a prospective multi-center study with over 2,000 patients. Primary endpoint was all-cause mortality and MI within 30 days with an initial trope less than 5. So remember, the last study was less than 3. And it's found a sensitivity of 98.2%. The caveat is that if you came in and had a high sensitivity troponin on your initial draw less than 5, and you had an MI, there were 8 patients, 7 of 8 of those were early presenters, less than 3 hours. And that's the concern that with our current algorithm, what we do is if they present less than 3 hours, we have to draw a repeat in 3 hours. However, so the sensitivity did drop in those early presenters, but if you look, there's only 2,000 patients in the study, and the number of patients that were in the early presenter group was only about 200 to 300. So is it really fair to draw an accurate conclusion from 200 to 300 patients in a study? I think it's hard to say at that point. The other question I would bring up to you, which I know some of you do here currently, is if someone comes in with 2 hours of chest pain, is it worth it to draw the trope at the 2 hours or to wait an hour and draw the troponin at 3 hours? Because if you think about it, you may be, I mean, it's a question to you guys to think about personally, but if you have the troponin at 2 hours and it's 10, well, what does that mean? To be honest, I don't, after going through the literature, I'm not sure. So our current algorithm, you repeat that means the patient is there in the department for 5 hours. It almost seems like, you know, if the patient was to wait an hour to come in, they'd have a more accurate diagnosis of concerned, not concerned, based on our algorithm. Some people are also finding that they'll draw the troponin at 2 hours, but repeat it within the hour and see where they're at that 3 hour mark. So there comes a clinical decision rule, and there's been consensus statements and review papers that have looked at, there's no one specific factor. There's not the troponin alone, aside from STEMI, there's not the ECG alone, there's no one thing, whether it radiates to both arms or not, that determines whether the patient is at risk for ACS. It's kind of the clinical picture. So we can use clinical decision rules to help us with regards to the troponins and the ECG. There's a vast amount of clinical decision rules. There's the heart score, which I'll talk about, the TIMI and the GRACE. A lot of the clinical decision rules that are used, we don't use them so much here in London. I know the clinical decision units in the States are using them. For example, the TIMI is, from my understanding, commonly used. But the TIMI was validated and originated from patients with defined ACS and who would benefit. The TIMI was initially developed to look at prognostically who does worse with patients with defined ACS, not necessarily all comers in an emerged population looking at adverse cardiac outcomes. So trying to incorporate this, these clinical decision rules with the high sensitivity troponins, the TRUST ADP was a prospective study, almost 1,000 patients, with the primary endpoint of MI within 30 days. The secondary endpoint was MACE, and you can see here that the median time of presentation for patients was actually less than 3 hours. So in order to be considered low risk for this accelerated protocol, of which there's many, you had to have a high sensitivity troponin T of less than 14 at presentation, a non-ischemic ECG at presentation, and a modified Goldman score less than or equal to 1. Now you can, as we're talking about all these studies, you can kind of pick flaws and see that there's inherent deficits in each study. The point that that I'm trying to make in this presentation is that yes, you can poke holes in individual studies, but there's a growing amount of evidence that overall there may be a better way and a more efficient way to do things. So you can see here that there may be some problems with the modified Goldman risk score in terms of pain not relieved by nitro. Well, we know based on studies that that's irrelevant. Whether the pain is relieved by nitro or not has no predictive value in terms of whether it's ACS related. Hypotension less than 100. I mean, if the patient's with chest pain and hypotension, that patient's going to be in our resus area, and I think there's immediate concern regardless. Pain lasting more than 60 minutes, does that make you consider unstable angina versus not? For me, it doesn't. So there are some problems with this. However, you can see that if they did fall into the low risk category for this TRUST ADP algorithm, which was about 40% of patients, and there's no repeats in this. This is, you get the patient in the front bubble, you see them, you have the troponin drawn within the hour, and immediately you have a disposition plan. So it had a sensitivity of 98.8% for the primary outcome and about 99% for the secondary outcome. Only one patient in this entire study that was considered low risk had an adverse event, and this is kind of coming back to what do we define as an adverse event. The one patient that was classified as low risk that reached either a primary or secondary outcome had a troponin initially of 13, and this again is high sensitivity troponin T that we use here. So if you can compare that and think what you would do with this patient, and on 6 hour repeat, not 3 hour, the repeat troponin was 20, but because the delta was more than 20%, they were considered positive and diagnosed as an NSTEMI. So we ask ourselves, are there any more validated scoring systems? Because that was talking about the modified Goldman score, which to be honest, I'd never heard of. And there was a rational clinical exam review in JAMA in 2015. They looked at nearly 3,000 articles, 58 met inclusion criteria. They did not use high sensitivity troponins for the reason that high sensitivity troponins, as I mentioned, are not widely available in the US. So the results, they found that specifically with the heart score and the TIMI score were two of the scores that they highlighted, which seem to be some of the more commonly used scoring systems. The heart score, if there's a high-risk heart score between 7 and 10, the likelihood ratio for an ACS was 13, as compared to the TIMI score, which is commonly used, of 6.8. Conversely, low-risk patients, or as well I should say, low-risk patients had a likelihood ratio of 0.2 as compared to the TIMI's 0.31. So just to introduce the heart score and where it came from, so this was I believe in 2011, it was pretty much just a group of guys in the Netherlands got together and thought, what do we care about in a patient that presents to the emerge with chest pain? We care, and the heart is a mnemonic, right? So we care about, and just to show you here, it only had 122 patients, but this was kind of a probing study to see what can we come up with. It was all comers to the emerge, and it was over a 3-month period. So history, ECG, age, risk factor, and troponin. And essentially, it looks complicated when you first look at it, but essentially the way it works is not concerned, very concerned, somewhere in the middle. So with the history, 0 points if you're not suspicious based on the story. 1 point if you're, or sorry, 2 points if you're very suspicious and you think, you know, I may consider calling cardiology regardless, no matter what the troponin shows. And 1 is moderately suspicious when you're kind of thinking, well, we'll see what the repeat choke shows. We'll sit on them for a bit, see how they do in the department. ECG as well, completely normal sinus, no changes. 2 would be significant ST depression. STEMI's obviously excluded because those patients don't need to be risk stratified. And 1 is the non-specific. Well, they've got chronic left bundle, maybe there's some repolarization abnormalities. I'm not sure what this isolated flip T wave looks like. The age, just remember 45 and 65, so 65 or greater, it's considered higher risk, 2 points, and less than 45, lower risk. Risk factors are the traditional risk factors that we use, and the troponin, because troponins will vary between sites, whether you use conventional troponin I, whether you use high sensitivity troponin I, troponin T. So what they did was they looked at normal being normal, and then 1 to 2 times the upper limit of normal, whatever that upper limit is, as being 1 point, and greater than 2 times the upper limit of normal for being 2 points. So in this kind of initial study that they did, they saw 1 patient that was considered a low-risk heart score had an adverse event. And you could see here that the heart score correlated with the adverse outcomes. The higher your heart score, the higher your risk of a major adverse cardiac event. So with very small numbers, obviously you can't really say anything about that. So what they did was they did a prospective observational study with nearly 2,500 patients. And this again is all comers to the emerge, presenting with chest pain. This is only the initial troponin and ECG. There's no repeats whatsoever in this. So the primary endpoint again is MACE within 6 weeks. Secondary endpoints, acute MI, ACS, or having performed coronary angiography within 3 months. So you can see here, the reason I put up this slide is just to show you guys that there's very good retention in the study and good adverse outcome events. So here, we're looking at the heart score, the TIMI, and the GRACE, because the TIMI and the GRACE were some of the commonly used risk stratifying protocols that were adopted. So if you compare the heart to the TIMI and the GRACE, over a third of patients that initially presented were able to be classified as low risk, with an adverse event rate of less than 2%. So the heart score was able to exclude MACE with greater than 98% certainty in about a third of patients, which is actually very good as compared to the TIMI's 34% with a 2.8% missed MACE per that group. And this is just to show you here that if you have a low risk heart score, you have a lower percentage risk of MACE as compared to a low risk TIMI or GRACE. And if you have a high-risk heart score, you have a much higher risk of MACE than as compared to the TIMI or the GRACE. And this comes to the 2 endpoints that it may not be just about ruling out an MI, but also who am I calling cardiology about sooner, and who are we more concerned for, even if the patient does show up at 2 hours with a troponin of 10. Is this patient concerning enough that I really want to do that 3-hour repeat? So they looked at the C statistic, the area under the curve, comparing the heart, the TIMI, the GRACE, the troponin, as well as the troponin and the ECG. So only the heart score performed statistically better than the ECG and the troponin. and that was independent of whether we were looking at MACE, acute myocardial infarction, or death, or ACS within 3 months. There was another study that was done that compared clinical decision rules. The heart score and the North American chest pain rule, and it also looked at clinical gestalt and serial troponins alone. So just to let you know that the heart score, as well as the clinical gestalt, both included the conventional sensitivity troponins. So the heart score was able to identify more patients for early discharge than clinical gestalt alone, with approximately the same sensitivity for ACS at 30 days. This study showed that there were only 2 missed patients with ACS. The initial patient had a negative initial stress test in the eMERGE, but unfortunately later in that month developed an out-of-hospital STEMI and VF arrest. And patient 2 had a positive exercise stress test in eMERGE, but refused an angiogram and was discharged. The caveat that I want to make here is that adding a 3-hour troponin to the initial heart score did not pick up any additional cases of ACS for this study. So coming back to that JAMA article that we mentioned that was done in 2015, and if you can remember, they looked at all studies between 1995 and 2015. They recommend that you can use one of the available clinical prediction rules, and should use one available clinical prediction rule, whatever yours may be, to help you risk stratify patients when you're considering ACS. It also mentioned that there were several accelerated diagnostic protocols that involve serial cardiac enzymes, so whether that's 1 hour or 2 hour, in low-risk patients that were accurately able to rule out ACS. There was a study done by, or a consensus put out by ILCOR, of which Dr. Wilfrey was a part of, that looked at the available evidence and stated that better to err on the side of caution. The evidence out there is evidence, but the evidence for individual studies is fairly weak. If you can see some of the studies that we put up, the numbers aren't great. 900, 1,000, 200, 2,000, kind of the higher limit of the studies that were done. There are a lot of studies being done, but not a lot of large studies with significant power to detect whether it's just an acute MI as opposed to the composite outcome of MACE. And given that high sensitivity troponins are newer and not widely adopted in the US, there's not a lot of evidence surrounding specifically high sensitivity troponins yet in terms of which accelerated diagnostic protocol is best and which is safest. So you can see here in the knowledge gaps, they quote that we encourage further studies to evaluate the combination of troponin and clinical risk scores. So given what we've talked about, we're thinking about doing a study here at LHSC, looking at, so we've talked, I hope from the study that you've gleaned that we feel that the heart score is a good score as compared to some of the other commonly used risk scoring systems such as the TIMI. But there hasn't been a lot of use or any really study that was done with high sensitivity to troponins and the heart score, whether it's an accelerated diagnostic protocol or not. And we feel that having 3 years of experience under our belt with these high sensitivity troponins, we have a bit of a jump start on other centers as well as the states for which it's not widely available yet.
So as we mentioned, this is intended to be a validation study of the heart score using high sensitivity troponins. So as per the current literature, this combination is not something that's been done on any kind of large scale anywhere yet. The heart score currently has a validation study that shows that yes, at a low heart score, 0 to 3, your risk of MACE is less than 2%. That's getting very close to that kind of benchmark of 1% of negative outcome. However, those things were all done with conventional troponins, and as you can imagine, when you're using 1, 2, and 3 times the normal limit, which basically is 50 for us on our high sensitivity if you compare it to the conventionals, going to a high sensitivity troponin using a cutoff of 14 should improve that quite a bit. So we should be well under, logically speaking, that 1% mark if we can do this. So this is a study that Nick, Dr. Collins-Theist, and I have been thinking about for the last few months now. We've talked to Dr. John Dry and the research team. We've also had some support from our chief, Dr. Adam Ducolo. To do this, we really do need to collect a lot of data. We're not talking about a few dozen or even a few hundred patients. To be able to do this and show any kind of an outcome and do the proper analysis, we need several thousand data points. So we're talking about calculating heart scores and then following up on outcomes on several thousand patients. So to that end, we are requesting your support, and the commitment that we're requesting from each and every one of you is that for every single patient that comes in and gets a troponin drawn, we're asking that you complete a very short form directly into Cerner. And the components on this form are basically going to be 3 boxes. Box number 1, your clinical gestalt, high, medium, low. Box number 2, your EKG interpretation, normal, grossly abnormal, and non-specific. And box number 3 is presence of risk factors, hypertension, dyslipidemia, smoking, etc. That's it. I'm not asking you to change your practice. I'm not asking you to do any kind of calculations or heart scores or anything. Just input the data. These are bits and pieces of information that you guys are likely already collecting on the patient as part of your history, and so it really shouldn't cause too much disruption in your workflow. It is a little bit of extra work. I know it's going to be somewhat annoying, but in the end, we believe that the outcome of the study is likely going to influence the way we look at ACS in the future. So, yes, lots of work for everybody for sure, but I can assure you that for every single form you complete, we're going to be working equally hard behind the scenes because we're going to be looking at that patient chart, following up for outcomes of ACS up until 30 days after the visit. So hopefully I've managed to sell you on the importance of this study and how important this will be for all of us.
You know, you have this 47-year-old guy, history of hypertension, hyperlipidemia. He's a non-smoker, but occasionally has 1 to 2 beers on weekends. The ECG you find unremarkable. What's that?
Dispute about the alcohol consumption.
I thought there might be. And the high sensitivity troponin at 10. So when you're calculating the heart score in terms of age, he's 0 points for, maybe 1 point for less than 45. So he would be greater than 45, so he'd have 1 point actually there, apologize. History, you found to be not concerning. He was out at the keg having a Billy Minor pie and had some epigastric pain. Past medical history, hypertension, dyslipidemia, so 1 point for 2 risk factors. The ECG being normal, 0 points, and the high sensitivity troponin as well being normal, so 0 points there. So on initial presentation, given this patient's story, ECG and troponin findings, you could save Scott the time for the repeat troponin and allow him for early discharge. The important thing to remember here is that what we want you guys to take away from this is that there is evidence emerging for increasing alternate protocols. The evidence right now is not clear which accelerated protocol is best. That's why we're looking into this. And there's no current recommendation as to should we repeat the troponin at 1 hour, at 2 hours? Is the heart score the way to go? We feel that it is, and we feel that the evidence is best for the heart score, especially within an emerged population. So we'd like to put this study out there and feel that our sensitivity would be improved given the fact that we have high sensitivity troponins available to us as compared to the conventional troponins that were used in some of the larger studies. So we've built in time for any questions or debate or points that you guys wanted to make, concerns that you had, because this is something that 5 years down the road, it would be nice to have, or a number of years down the road, an alternate protocol with evidence to support you for discharging a patient that you feel is low risk, discharging them home. So is there anything that you guys wanted to bring up or ask about, or no? Pretty quiet.
So we'll take the last second to make some questions. Feel free, anybody? Derek, I see you're itching up there right now. So.
Yeah.
We're actually just talking, I'll go ahead to chime in about Andrew McCurdy's abstracts. I think you were right there last year at Cave, AJ, that he presented. And my take home from that, it may be a little more aggressive than what you're even presenting here, and that actually comes in the door, and they've got a normal ECG, and they have a troponin down at the door regardless of the duration of their history. If it's less than 3 and the high sensitivity trope, they can go. If it's 2 minutes of chest pain or whatever, as long as the trope's 0 and the ECG is normal, they can go.
And again, that comes back to one of the studies that I brought up that showed that the sensitivity in early presenters dropped from, all comers, it was about 98%, to early presenters, the sensitivity dropped to about 94%, albeit there was only, in that cohort of early presenters, there was only about 300 patients. So it's really maybe not enough to say, you know, how true that holds. But that's part of the reason that we wanted to do this study, was to see, aside from the undetectable troponin, which may be an avenue out there, are there any clinical risk factors, some of which are evaluated in the heart score, that we really care about and that would influence us to say, can we catch these extra patients that present early, and who should we do repeats on? Is that fair?
Just to add to that, so there's 2 studies here presented to exactly that question about less than 3, so undetectable troponins, and you're very correct in saying that yes, the risk is extremely low. I am aware of Andrew McRae's paper last year at CAPE as well, and we did the same study basically here last year as well that showed that yes, if you have an undetectable troponin less than 3, for all comers, your risk is basically less than 0.5%. That's very low and well under the 1% benchmark. But we did have one study that showed that if you look at just the early presenters, not just everybody with less than 3, but the group that came in at under the 3 mark, there's a little bit of discrepancy there. The sensitivity drops to something like 6% of miss rate, right? So the error bars on that are fairly high because of the low numbers, so it's hard to say what exactly it is, but 94% is not quite at the limit we're looking for. So there is some dissent within the literature. So yes, the way I practice right now, less than 3, I have to have a darn high pretest probability before I consider doing a repeat troponin. But I would say, is that supported by the literature? Maybe. Yes?
In your research protocol, when we're going to be answering the questions on the computer about our feeling low, medium, or high risk, is that what we're going to get? What data should we have available? Are we going to have that's based on ECG and history and physical?
That's correct. So that's basically after you've done your assessment of the patient, as you're clicking on the troponin or haven't looked at the troponin yet, what is your gestalt? Is this person a high risk, medium risk, or low risk? It's not meant to be a super clinical, you have certain criteria you have to tick off. It's just your overall opinion of the patient.
So in certain circumstances, the troponin, which has been already ordered by medical directive, is going to be maybe back.
That's right.
So, are we going to be blinded to what that troponin shows when we're giving our...
Ideally, unfortunately, that's not likely going to be doable. So again, I am looking for your overall opinion of the patient, hopefully without the knowledge of the troponin. But
And to be fair, as we're doing the EDST more and more, oftentimes you're seeing the patient, within the hour. It takes about an hour for the troponin to come back. We're seeing them within the first hour, or even before the troponin is drawn, and have only the ECG available.
It's an unrelated question. It's maybe, I guess, more to Nick and yourself who've done the literature searching. Have you ever come across anything about the sensitivity of an ECG to the point of whether the ECG is when the patient is symptomatic or not?
In terms of...
well, I mean, to myself, I look at an ECG when a patient is having pain to be of a lot more value or some increased value to an ECG that has been done when the patient has come to us and is now pain-free. And I mean, anyone who's worked with me knows I quite frequently ask when the ECG is shown, were they having pain with that ECG or not?
For sure, and I haven't specifically come across any anything evaluating sensitivity, specificity compared to pain-free versus during pain. Obviously, that's additionally concerning if when they're not having pain, their ECG is normal, and then their discomfort causes changes. So I think in that patient, that would be high risk. So, I mean.
I just had a question about how we'll be filling out the data. Will it be on a paper form or will it be online? Because if it is online, is that not occurring at the time that the troponin is being ordered? And in that case, would it be the nurses who are filling it out?
So the answer to that question is, ideally we would, or at all costs, trying to avoid a paper form for the fear of it's going to get lost in the shuffle. There's already a lot of papers, whether it's the Fry or things like that, and we feel that buy-in would be significantly less. So we are meeting, working with the people at Hugo and to develop something for this in terms of a pop-up whenever you order the troponin. The trick is going to be oftentimes the troponins are ordered by the nurses. So is there a way to have the, when you enter in the patient's chart, despite the fact that the nurse has already entered the troponin and closed this little window, because this will be filled out by staff or maybe with the help of residents as well. So that's kind of in the works and still in discussion with IT.
No, what we're trying to envision is a pop-up in Hugo that basically you click whoever clicks on the troponin, if you order it, you're going to have kind of like the CT checklist that pops up, this thing that pops up. Now, the nurses are going to be able to X out of it, and hopefully Hugo or the Cerner system will be able to discriminate between a nurse and a doc logged into the system. But this will hopefully keep on popping up until somebody fills it in. And there will be an exclusion box where you can kind of tap out of it if you're like, I would not have ordered a troponin, or I'm doing this because for other reasons other than chest pain or whatever, because we want to exclude the patients that we're not really concerned about in the first place. But ideally, that's the way we envision this. We're still meeting with Cerner trying to figure out how to make this work. It may not work that automatically. You may actually have to manually go in and fill out a power form, but we're hoping to make it automatic. Yes?
Just one other comment just about the early troponins. Sort of, it doesn't really make clinical sense to me to say that your troponin at time 0 is really diagnostic. There must be a cutoff point eventually that's related to time. And I think that right now you're not really supported by like AHA guidelines if you're discharging people with just one troponin that are less than a 3-hour mark.
Yeah, and that's a big reason for doing the study is that you're not supported in the literature yet. And there's fear among physicians that, despite the fact that I know this patient is low risk, I feel that there's like a less than 1% chance that they have an adverse event. But if they do, I'm on the hook because I have nothing to stand behind. If they were to come back with a query and STEMI, there's nothing in the literature showing that I shouldn't have repeated that 3-hour troponin. And I think that there's some value, and especially with our strained resource and all the the bed blocking in not only London but Canadian emerges, it may be of huge benefit to be able to discharge patients earlier. And the studies that were done were discharging 30-40% of patients at the time of whether the diagnostic protocol was accelerated 2-hour or at the time of seeing the patient. And like you say, everything is not based solely on the troponin, which is where the risk scores come in, because troponin and ECG alone, even if the troponin is repeated, the sensitivity is not there for a missed MACE of less than 1%.
Laura, I just want to speak to that a little because I think you've kind of hit the question on the head there, which is basically, should we be doing this now or not? We've presented a lot of literature right now about doing basically one troponin, lower scores, send home kind of stuff. And there are some of these papers that are really good, like, less than 2%, 2,000 patients. Like, these are decent studies. But you're right, AHA does not support this at this time. ILCOR, that Dr. Wilfrey was a member of, is saying no, even a 2-hour troponin is not something that we're endorsing at this point. There's just not enough strong evidence, and I can't disagree with that. The problem with these studies is all of these studies are a little bit different. They use slightly different assays, different cutoffs, different endpoints, and so it's hard to put it all together. We have one systematic review from JAMA, which is not some small paper, that says, yes, go ahead and use heart score or other risk stratification tools. These are good things. Then you have ILCOR that comes in and says, nah, not really. We're just not there yet. So it's tough to say what should we be doing. So I'd argue that in terms of the data we have right now and the literature we've done, there is growing evidence for moving to single trope, low risk, able to discharge home. Are we there yet? I can't say definitively. The research just isn't there at this point. So the safe option for now would be following our current protocol, doing the 3-hour troponins, delta of 10 over 3 hours for basically everybody. And that's basically what our algorithm says. However, I'd argue that that's only a safe option if you're actually following the algorithm. And we know for a fact that a lot of us here are not following the algorithm. We oftentimes cut the corners, right? I think, for example, the tropes of 14 to 50, there's no box that says, based on renal failure or pre-existing condition or whatnot, you can discharge a patient home. If you have a trope of 14 to 50, as per ILCOR, AHA, and our current guideline, that person needs a second trope. And I can tell you that only about 20% of our current patients right now are getting that second troponin. Lots of them are going home. So if you're going to discharge a patient based on a trope of 17, and you flip back and say, well, 2 weeks ago it was 17, not amazing, you can send them home, is that really based on evidence? Not really. So if you're going to do that, I would argue using something like the heart score that has at least some evidence is a much better place to start. So that's kind of where we're at with our current. I'd say to be safe, use the current algorithm. If you're not, then you might want to bounce it off something like a heart score. Yeah.
I guess just overall a couple questions, and some maybe show my ignorance, but I mean, there's some old studies that show that just based on our history and our physical and our ECG that we're 95 to 98% sensitive,
Yes.
just based on those things, and that all this slicing and dicing to get down to this 0.5. We don't have any tests that are 99% sensitive, and this is just insanity. I guess I would like to see somewhere where you're measuring the harms. I mean, look at those those things that they're calling M-STEM, because they're a pile of bullshit. They've done a PCI for no good reason. And then they're kind of clean corner, oh, but it's still an M-STEMI. I mean, I guess that's possible, but what, we know that there's a 1% to 2% stroke rate with doing a cath and all these kind of things, but where are the harms we're doing by chasing and the costs we're doing by chasing this insane realistic goal of picking up every single person who's possibly having some kind of ACS? It just seems to be crazy. And also, second point, I guess, maybe some other people can comment on the literature, but I've been teaching, maybe I've been totally wrong, but I thought there were several papers out there saying that, in the emerge setting, cardiac risk factors are irrelevant. Those were developed from the Framingham study, which held in town for 25 years. And yes, if you're fat, you smoke, and you eat like a pig, and you're diabetic, yeah, you're at risk. But in the emerge, when you come in and say, when you come to emerge and say, I'm having chest pain or I'm short of breath, that complaint by itself so overwhelms these little smoking that they become irrelevant.
So we agree with you in large part, and that's part of the reason that we're trying to do this study, to say that maybe we are sending too many patients along or doing too many repeats. And you're right with the risk factors. The history in clinical gestalt is the most important part. But some of the studies that were done that we showed that using this scoring system, which if you look at the hard score, break it down, it's really just clinical gestalt that we're trying to validate. Because, is your history concerning or it's not? Is the ECG concerning or it's not? Age, is it concerning or it's not? I mean, but with that scoring system, it was shown that we could discharge, an additional 6.5% of patients early with evidence behind it, as opposed to, and I know that we feel that our clinical gestalt is good, but if there's a heart score or a scoring system out there that can allow us to discharge safely an additional 7% of patients, maybe there might be some benefit in that. And if you're saying 95% is the clinical gestalt, I mean, the generally accepted missed event rate is 1%. And I understand what you're saying, that there is definitely some harm in over-investigating. But right now, for what's out there, less than 1% for missed MI is the kind of what people are going for.
So, Derek, just in counterpoint to your argument, which I agree with. I mean, where do we draw the line, right? I mean, even CT abdomens, looking for the stuff we look for, are somewhere in the low 90s range for sensitivity. So going to 99 seems ridiculous, but that is what the international consensus for now seems to be, is if you're going to miss somebody with MI, you better be sure 99% of the time is kind of what the consensus is. And just to throw it out there, for those of you who look at Dialogue once in a while, our nice little publication from the CPSO, have a look at the last issue, and there is an emerge doc who's in there for precisely the type of stuff we're talking about. Carl Theakston showed me this not too long ago. It's actually fairly concerning, where a patient came in with query chest pain, there wasn't a repeat done. I don't even know if there's actually harm done to the patient, that's not explained, but this ended up in CPSO with consequences as a result of that. So a good thing to look at, and it just shows you, like, if you're being judged by your peers, like, what is the acceptable miss rate, and is your practice in line with that? I don't know the actual answer to that, but yes.
The timing of that CPSO complaint, though, was before high sensitivity stroke.
That's correct. As is a lot of the studies were showing, right? So,
most hospitals in Ontario are not using high sensitivity.
Yeah, and the way I read it was the small issue was the clinical concern. The big issue in that CPSO complaint was that the doctor was a jerk during the investigation. At least that's what it seemed to sound like.
And I think there's a lot of studies show that as long as you're you and the patient on the same page, you're probably going to be all right. I mean,
not just to the patient, to the CPSO.
Oh.
Yeah, which is never a good idea.
And the point that I'd like to make is, Derek, I think that not everybody feels there's a huge variation in terms of how comfortable people are with whether it's ACS or other presentations. You look at with the report cards that they're giving out in terms of how many tests are ordered. Some people are ordering a lot more, some people are ordering a lot less. And what does help some people is finding the evidence out there to support them. I mean, not everybody may need that. Some people may say that I feel comfortable letting this patient go based on the risk that I'm willing to accept. But the answer is that not everybody is as comfortable as you may be, or others may be. There's a huge variation.
And Derek, to just add that, as a group, when we look at our empirical data, we know for a fact that we're not really following the current algorithm to a T. We also know for a fact that we are ordering too many repeat troponins as it stands. So we're kind of somewhere between the literature and a current algorithm. And I think it's important for us to actually put out some literature saying what we're doing here is actually totally reasonable, and more importantly, we can do better than what we're doing right now. And that's really where we want to take this. Because right now, the evidence for what a lot of us are doing is a little bit fluffy, if you will. So that's where we'd like to take this, and that's why we want to do the study here, to say, yes, early discharge 1 troponin, not always unreasonable, and in fact, we can do more of it. So that's why we're doing this study.